Thanks, Rahul, for giving me the opportunity to present. And I discussed this case after angiogram to Dr. Rahul only. He was an 8-year child, and we thought we will do only DSA, but because 8 year we done DSA under GA. And after the procedure, I discussed this case with Dr. Rahul. He belongs to, I think, somewhere from Bihar only, and we embolized this case with perimetric fistulas are not very common to find out. So 8-year male, paraparesis, and power was 2/5 for last 6 months with bladder involvement, and at D11 below you can see there's a flowets, marked flowets, and along with this there's some pouch kind of thing, maybe venous ectasia, and then you can see there's a hyperintensity suggestive of venous congestion. This is the axial view of this case. This is the contrast MRI, and you can see this venous pouch having the contrast stagnation here. This is the axial view. The another view, again, you can see these serpiginous flowets, and the venous congestion is extending up to the lower cervical level. So from the D11, from L1 to it was extended to the lower cervical. So there's a marked venous congestion at the cervical level. So that's the spinal DSA. So in this case, the Adamski's was arising from the left D8, and the fistula was at the level of right L1. So this is the lumbar artery. This is the radiculomedullary artery going to the medullary veins, and there's a venous pouch or venous ectasia. This is the late arterial and venous phase, and you can see the veins are markedly dilated. Perimedullary veins, medullary veins, and perimedullary veins are markedly dilated, and there is a Batson venous plexus. This is the lateral view, and you can see this is lying posteriorly. This fistula is lying posterior to the cord. So these are the other images. I think go to the, yeah. So this is the drawing made by Dr. Rahul. This is the segmental artery at the level of L1, and then it is a ascending segment of the radiculomedullary artery. Here there may be connection with the pile arteries also, and then this artery is going down, descending segment, and then this is the entry point to the fistula. There's a venous aneurysm, and there's a congestive spinal venous plexus. So this is the whole discussion of this fistula. This is the lateral view. These are the microcatheterization by the magic catheter. So here, so the first microcatheter is up to this proximal segment, and then we went to more depth. So this is the microcatheter, and now the microcatheter is more advanced, just near about the this venous aneurysm or venous pouch. So this is the entry point of the fistula, and our microcatheter is just at the entry point of the fistula. So this is the microcatheter injection. Around 50% glue was used because it is a high flow fistula, so we use around 50% of the glue with lipidol. So this is the contrast in the venous pouch, and there's proximal part of the glue. This is the we have given injection Dexona 1 cc/BD and LMWH because he was 8 years, so we have given 1,500 units of the LMWH for 3 days only. And he was discharged after around 10 days. Power was 3/5 at the time of discharge. But he lost to follow-up. We tried to contact him, but luckily phone is not replying. So this is the video. So this is artery Madam quiz. And this is the fistulous connection. Marked venous congestion. This is the lateral view. Lateral view. Venous congestion is up to cervical level. This is the microcatheterization. Microcatheterization. Microcatheter site of fistula. And that is glue injection. So, as perimetric fistulas are very rare, basically they are also called type 4 spinal arteriovenous malformation, and there's an abnormal connection between the spinal arteries and the medullary vein. The fistula is on the spinal cord, not within the spinal cord. Sorry, going back. The incidence is around 13% all of the all vascular malformation, but some of the reports it says as high as 34%. About 2/3 patients are younger than 25 years of age. Three type of perimedullary arteriovenous fistula has been described. So type 1 has only one spinal artery, usually anti-spinal artery, and then followed by spinal medullary vein. And in the type B, usually we have one anti-spinal artery, but multiple post-spinal arteries are there which supply the fistula. And in type C, there's a multiple anti-spinal arteries are there, and the fistula is very huge and very giant fistula is there with multiple enlarged feeders. So in this case, it was type 1. We do all cases first spinal DSA and try to find where the fistula is, because we don't localize most of the time with the MR angio, because we don't have good technicians like Dr. Rahul has. So we first do DSA, we try to analyze what kind of fistula it is. Most of the time I discuss with Dr. Rahul for planning, and then do procedures. We have around 6 cases of perimedullary fistula, and some of the cases when we are not able to reach the nidus, particularly in the dural fistula, we have Dr. Gandhi who do surgeries for this. So we have around 7 cases where the surgery has been performed by Dr. Gandhi. So thanks to my department, neurosurgery, neurology, Dr. Gandhi, and thanks to Rahul.
Thank you, sir, for that excellent case presentation. I remember this. This was, I think, almost 8 years old. 8-9 years back, 2015. 16. So this was a very interesting case. Any questions on this case or any of the cases? Because now we will move into the surgical aspects of spinal cord arteriovenous malformations.